Everybody. Welcome to our Riverland Academy of Clinical Excellence Grand Round. It's great to be back together again with the opportunity to broaden our minds and engage with some of the state-of-the-art ideas that are around the world in rural and remote health in particular, and also to broaden our networks with thought leaders from around the world. And it's a great pleasure today to be able to hear on Ngarrindjeri country, to be able to welcome Professor Michael Kidd, a friend of rural and remote Australians and somebody well known to this region, particularly through his role as Executive Dean of the Faculty of Health Sciences at Flinders University, but known throughout the world as a former president of the World Organisation of Family Medicine and General Practice, and of course here locally as president of the RACGP. Having said all that, and the fact that he is a practicing family physician, general practitioner, most of you will know him as one of the faces on TV for the last 2 years, as in his current role as a Deputy Chief Medical Officer for the Commonwealth Government. He's been in charge of the primary healthcare response for COVID. And the poor fella has been up at all times in front of the TV cameras, answering questions and helping guide our response and the safety and health that so many of us have enjoyed over the last 2 years is in no small part due to the influence that he's been able to have at that Commonwealth level. It's nice to know that practicing primary care clinicians are able to influence our government and influence our policy. So today we have the pleasure of hearing Michael's perspectives, and he has offered to leave plenty of time for questions. So get out your notebooks, be respectful, as we always are, and hopefully we have a great time to answer some questions from everybody. So welcome, Michael, and it's over to you.
Thank you, Paul, and thank you for that warm introduction. I wish my mum had been online to hear it. She would have loved it. Thank you, everybody, for the opportunity to join with you. I know, looking at the names, lots of friends from the region. It's a real honour and privilege to join you. I wanted to acknowledge the traditional owners of the lands where each of us is meeting today, and hope that you all had a wonderful NAIDOC week last week and was able to engage in celebrating some of the wonderful achievements and culture and history from Aboriginal and Torres Strait Islander people in this great country. And I also want to say a huge thank you to all of you. The last 2.5 years have been extraordinary in all our lives, but what's also been extraordinary has been the way that healthcare professionals right across this country have stood up and provided care and service when it most matters to our patients, to our communities, to the population of our country. I know that many of you are feeling exhausted. We're now, of course, going into a new wave with these Omicron BA4, BA5 subvariants, and perhaps also this new Centaurus subvariant, which is rearing its ugly head as well. We're expecting at least the next 4 to 6 weeks that we're going to have a dramatic increase in the number of people infected with COVID-19. A lot of people who are infected early in the year are going to be infected again. This is going to put huge stress and strain on our healthcare system and particularly on our healthcare workforce. And so please look after yourself, look after each other during what I think is going to be a challenging time again for all of us. The focus of the government's approach at the moment is to try and make sure that everybody is up to date with their vaccines, particularly that important 4th dose. We were calling it the winter dose, but it's now the 4th dose. Eligibility, of course, has been expanded to anyone 50 and over. They're recommended to get that 4th dose within after 3 months or more after the 3rd dose, or 3 months or more after being infected with COVID-19. The 4th dose is also available to people 30 and above if they wish. And importantly, we also now have these oral treatments available. Lagevrio, molnupiravir, came onto the PBS on the 1st of March, and Paxlovid, which came onto the PBS on the 1st of May. We've already had over 85,000 prescriptions for these oral treatments written by GPs and prescribing nurse practitioners across the country and dispensed by community pharmacy. But on Sunday, the Minister for Health, the Honourable Mark Butler MP, announced the expanded eligibility for these treatments. Now, these treatments are incredibly effective in preventing people who are at high risk from becoming seriously unwell from COVID-19 and at risk of being hospitalised and at risk of death. And we've seen how effective they are in outbreaks in residential aged care facilities over the last few months. A reminder that eligibility, anyone 70 years and over who has a positive RAT test or a positive PCR test can get a prescription for these one of these treatments, whether or not they have symptoms. So we're keen to get the treatments into people before they become symptomatic, recognising how quickly elderly people can deteriorate. They're also available for people 50 and above with 2 risk factors, Aboriginal and Torres Strait Islander people aged 30 and above with 2 risk factors, and people aged 18 and above with immunocompromise, including people with severe disability. Again, this is going to place a lot of pressure on primary care and on the emergency departments, but these treatments are going to help keep people out of our hospitals and hopefully reduce the death toll. I think it's been a real shock to many people in Australia to see that we've reached over 10,000 deaths from COVID-19, over 8,000 of those deaths occurring since the beginning of this year, and we've had over 2,000 deaths in residential aged care facilities alone since the beginning of this year. Paul asked me to just talk briefly about how this all fits in the context of reform, and we have a new federal government which came in and said they were going to implement the 10-year primary care reform plan, which had been under development for the last couple of years. Already we've implemented one of the major reforms, which was rolling out telehealth as a core part of primary care services supported through the Medicare Benefits Schedule. We've had over 110 million consultations between Australians and their chosen healthcare providers using either video calls or telephone calls and subsidised under the MBS. So that's rolled out. We've got e-prescriptions, which have rolled out as a digital health reform during the pandemic. And we've had many tens of thousands of prescriptions which have been transmitted electronically for patients to their pharmacies of choice. We've now looking with the 10-year plan at the implementation of voluntary patient enrolment, allowing people, particularly people with chronic disease, to enrol in the primary care service of their choice, the general practice of their choice, and for that practice to get additional support to provide high quality continuity of care, multidisciplinary care in many cases, to people with chronic disease. This is a very exciting development in Australia, and allows people to formalise the arrangements which most of us have. Most of us only attend the one general practice for most of our primary care needs, and this allows us to formalise that and improve the quality of care that we're providing to people across the country as well. Another one of the reforms announced by the federal government during the election campaign was expanding the support of integrating more primary care with emergency care through urgent clinics. urgent care clinics that's being developed in partnership with each of the states and territories, because already each of the states and territories has their own systems in place to support the provision of primary care to people attending emergency departments. There's a process called Strengthening Medicare underway, with a new task force being chaired by Minister Butler, with representation from the major medical, nursing and allied health peaks, looking at how we can strengthen Medicare in order to improve the care being provided to the community, but also relieve pressure on our emergency departments and our hospitals as well. And there's going to be a very strong input from rural and remote healthcare into that task force through the engagement of ACRRM and other groups in that process. So there's a lot happening. Paul, I thought I'd stop there and welcome any questions that people may have. Nothing's off limits.
Thank you, Michael. That's a very broad range of topics, and I have people's names up, and please use the hand signal if you wish to ask a question. I might ask a question just to get going. Michael, you mentioned patient enrolment, and you mentioned general practice specifically. Our LHN sees very much an integration between general practice, the hospital health services, our community care health services, mental health services, etc. How do you see patient enrolment potentially changing the organisation or the business structure of what up to now are very separate organisations? We have a separate general practice, we have a separate physiotherapist, we have a separate mental health division, we have a separate hospital. How do you see that might evolve over time?
Well, one of the things that has been a positive outcome from the pandemic, if there can be anything positive coming out of a pandemic, has been the really strong integration between primary care and public health that we've seen, particularly the state and territories responsible for public health, the primary care services through particularly the MBS subsidised services through general practice and elsewhere. And I think we can build on those linkages which have occurred. There's been a lot more understanding of what people on either side of the divide do. Now, I know in rural areas that often people are working on both sides of the divide, so you understand really well what the challenges are in a general practice in the local hospital setting. What I hope with the voluntary patient enrolment is that people will enrol with their general practice. This is a scheme which will be funded under the MBS, but that through that the practices will have resources to be able to better integrate with other services. Now, it may mean opening up room in their general practice for people, physios, psychologists, others, to actually be working within the practice, to have arrangements with the local health district on, can people who are paid under local health district come and spend some of their time working in the community, in the practices, creating, if you like, one-stop primary care shops. Now, we've seen models of this throughout Australia for many, many years, but what I hope through the voluntary patient enrolment is that there's going to be even more impetus for this to happen. We know that that high quality care of many people with chronic conditions, especially with comorbid chronic conditions, requires the involvement of not just a GP, but a whole primary care team with community nurses, allied health professionals, the community pharmacists, and often other consultant specialists being involved in that care as well. From the point of view of patients being able to go to the one place to get access to all those services and to have the healthcare providers working in the one place being able to talk to each other is going to be a real boon if that's possible. Of course, in smaller settings, people will still need to move around, but hopefully we'll see some greater communication occurring as well.
Thanks, Michael. I'll stay on the, I'm waiting for hands to go up, but I'll stay on the vision sort of side of things. For Tick, I'm sure there may be some questions later about the specifics of COVID and Omicron specific vaccinations and et cetera that you may want to talk about. But you mentioned telehealth. As you say, COVID has really fast-tracked your agenda to get telehealth ubiquitous across our system, which is fabulous. And yet now it seems that that's contracting a bit. So there was much, many more things we could do with telehealth. Now it's sort of less because it was seen as a COVID initiative. Rather than a health service reform that just gets more and more business as usual. Where do you see telehealth going? Is it going to be possible to do a lot of your chronic disease management via telehealth? Or is it really only going to be your item B's telehealth as a last resort approach? What's your vision for telehealth and business as usual going forward?
Yeah, well, currently, of course, it's pandemic as usual rather than business as usual, but we'll see where we go. What we envisage, of course, is that there'll be a blend of face-to-face consultations and telehealth consultations, whether they're through using the telephone or through using video calls. And we're hoping to see an increase in the use of video calls where that's possible. Where we know, of course, that many patients don't have access to computers or smartphones or iPads to be able to make those video calls, and the telephone is more useful, more helpful, particularly for many elderly people and people living in areas where bandwidth may be a problem. We've seen a focus, a government decision to try and encourage when a longer consultation is needed to have that done using video rather than telephone. We do know that when people do calls on the telephone, often they're distracted by other things which are happening around them, and their attention may wane, particularly if you're chatting on the phone for more than 20 minutes. A lot of the things that we need to do and the messages we need to impart as treating clinicians can be done within that 20-minute phone call. And often, if you're needing to spend more time, then you're moving into the phase where face-to-face is needed. Physical examination remains absolutely core to the work that we do in general practice, and so there is a requirement for people to have had a face-to-face consultation with their local general practice within the last 12 months in order to be eligible for the Medicare item numbers for telehealth. I think, again, that's a reflection of provision of good care, but a lot of those restrictions move to one side when we have substantial COVID outbreaks, because of course if people are diagnosed with COVID-19, we want them isolating at home and not coming into general practices and emergency rooms and community pharmacies unless they're significantly unwell and need to be attending. So I think telehealth will evolve over time. It's really important that the professional colleges are very involved in determining the standards for the use of telehealth. We know that every time we introduce new technology into healthcare, we introduce a whole range of new potential errors and safety risks. So we all need to be involved in how this evolves and how we use it in a way which improves the quality of care and doesn't compromise care for our patients.
Yeah, thanks, Michael. Certainly as a director of the Medical Insurance Group Australia, we're looking very much at the telehealth and the the potential for increased risks, litigation, etc. And it's a whole new world. Thanks for that. Gerarda Burgess is one of our interns and has a question. Gerarda.
Thank you very much, Prof. Lilly and Professor Kidd. I guess it sounds like you've been doing a lot of future planning in terms of 10-year plans for healthcare and that picture. Where do you kind of see rural generalists fitting into that story, and not just kind of medical, but also our allied health and kind of nursing generalists? And what's the plan to kind of support them moving forward in a rural healthcare system that sometimes can feel a bit like it's under a bit of crisis at the moment?
Yeah, thanks, Gerarda. Great question. And of course, Paul and many others have been working in this field very diligently now for decades on all that we can do to support and expand our rural health workforce. And as you rightly point out, it's not just doctors, it's nurses, allied health professionals, pharmacists, consultant specialists, just everybody. There's a boost in training for rural generalists. So at the end of this year, we moved to college-led training being run by ACRRM and by the RACGP, and an increase in the number of training positions with both colleges for people training to be recognised as rural generalists. And so that's fantastic to see. A lot of excellent experiences being organised for the registrars who'll be going through those programs. Paul can give you a lecture for hours on how we boost the rural workforce through programs to encourage enrolment in health courses from people who've grown up in rural areas, providing that training in rural areas, as of course happens in the Riverland area. It's one of the pioneering regions in the whole world for working really closely with the local communities and the local region on developing homegrown rural workforce for the population. So I think there's a lot happening there. I think it's really exciting. I think if I was going back to the start of my career, I'd be wanting to train as a rural generalist because of just that great diversity. And Paul, we probably did. You know, we got advanced obstetric skills and anaesthetic skills and emergency skills as part of our training, as well as being excellent providers of primary care to little children up to the very elderly in our local communities. Thanks, Gerarda.
Thank you.
Thanks, Michael. I might move a question across to COVID, and the one I foreshadowed before. You've mentioned the fourth dose. Just recently, it's been announced that the TGA is looking at Omicron-specific vaccinations, and it's been foreshadowed that this may be the way that things are moving. So with an announcement that there's an Omicron-specific vaccination being considered, and people are being suggested to have a fourth dose of the vaccination that was prepared for Alpha in the COVID nomenclature. What's your take on, should people be going out and getting a fourth, thinking there may be a fifth very soon, or should we be waiting for the Omicron specific? What's the talk around the TGA and around people who are leading this policy?
Well, first, we need to be dealing with what we've currently got. And so please do not delay vaccinating people or vaccinating yourself. Make sure you keep your vaccines up to date. Don't wait for what may be around the corner. We need to be managing what's happening right now. And what we know is that people who had their third dose 6 or more months ago, which is many of us, are now becoming an increasing risk of becoming severely unwell if we contract COVID-19. So please get that booster dose, that fourth dose now, and we'll watch and see what happens. The Omicron-specific vaccines, most of them have been developed for BA1, BA2. We, of course, are now at BA4, BA5, and the BA Centaurus, which has just appeared. So whether the BA1, BA2 are going to be any more effective than what we've currently got, we don't know. But at the moment, the vaccines that we do have are proving to be highly effective against severe disease with all the Omicron subvariants. We are seeing the immune escape. We're seeing people who get infected getting sick and being able to transmit to others. But what we're not seeing is very large numbers of people becoming severely unwell. So don't wait.
Yeah, it's great to have a really clear message there. A similar question, you mentioned the oral antivirals that have been a central part of the primary care strategy, molnupiravir and Paxlovid in particular. Of course, they were also developed for older strains. So what sort of evidence are you using for their effectiveness with these newer strains?
Well, we're seeing this in real world experience. So we pre-deployed molnupiravir, Lagevrio, out to residential aged care facilities and Aboriginal community controlled health organisations back in February before the listing on the Pharmaceutical Benefits Scheme. As I mentioned, we've had over 10,000 people in residential aged care facilities prescribed and dispensed these treatments. And what we're seeing is people, the vast majority of people who get these treatments not becoming severely unwell. Many people, if we can get the treatments into them before they become symptomatic, when they have their first positive test, are not developing any symptoms at all. And this is in very frail elderly people with complex comorbidities. So these treatments are effective. They are working. They are helping to reduce the death toll from COVID-19 and reduce the impact on our hospitals. Despite that, though, we are seeing a rise in hospitalisations. Just over the last 2 weeks, we've gone from just over 3,000 people with COVID in hospital to well over 4,000 people in hospital. It's a reflection of the surge. As we get greater and greater numbers, even a tiny percentage of people becoming severely unwell translates into large numbers of people turning up to hospital, and tragically will translate into significant numbers of people losing their lives as well. What we've also seen is many of the people who lose their lives are people who have not had the first, second or third doses of their vaccines. We know the fourth dose is going to provide that very important added level of protection as well. So again, I'll just reinforce it's so important that everyone in Australia is up to date. Don't rely on the oral treatments as a replacement for vaccination, as some people are doing. Everyone needs to be vaccinated.
Thank you for that really clear advice. You opened by thanking us for the work that we've been doing, and certainly you're right. People are tired. People are finding it difficult working with a significant furloughing with the strain and still some of the unknown. But we're in a much different and better position than we were 2 years ago. And so from our LHN, thank you for your part in guiding our country to a safer place, but a place that we haven't, as you say, got back to business as usual in any way, shape or form yet. It's still COVID as usual, or pandemic as usual. Thank you very much for the time you've spent with us. Thanks for the clear guidance, and we look forward to continuing to work together to make this country of ours all that it can be.
Thank you, Paul, and thank you, everybody. Real privilege to be able to join you today, and look forward to doing it again. I'm just about to hop off and talk to the radios. So.
I saw the phone go off, so you better get going. Everybody, thank you very much.